Hello, everyone, and welcome to the topper session. We have Dr. Atharva with us, who has secured rank 2, and it's my great pleasure to meet him once again. We have had interactions in the past, but first of all, heartiest congratulations, big congratulations. You've been trying to get through the IDC, but just first of all, why don't you introduce yourself to our audience?
Yes, sir. Sir, I did my MBBS from Government Medical College in Nagpur. I had joined in 2014 batch. Further, thereafter, I did my MD medicine from Agartala Government Medical College, Agartala, Tripura. I had joined in 2020 batch. Then I passed out in the year 2023. Uh, I had secured a NEET SS rank of 1764, but I thought that I was not well prepared then. So I should take a drop, I felt at that time. Then subsequently, I appeared for INISS in October last year, which I didn't qualify. I had a score of around 26 marks. Then in this April, I gave again INISS for DM Infectious. I had a score of 39 or 38 marks. I am unable to recall at present. And this time I qualified and luckily made it through the interview. It was all without with your guidance, sir.
No problem. All the best. And the other thing I just wanted to know, although I know why you're passionate about ID, but just if you could share, why did you want to pursue ID and what do you think of the branch in general?
So I personally, when I joined as a MD resident in Agartala, we used to get a lot of BSF soldiers with tropical diseases. So I had a good exposure in tropical diseases. Also, as we all know, sir, northeastern states are has a high burden of IV drug abuse. So each admission day, you will get at least one infective endocarditis. Some may be culture positive, some may be culture negative, and a large chunk of HIV, yeah, hepatitis B, hepatitis C, with their opportunistic infections and other manifestations. Plus, these patients, there are all complexities associated with this, some other comorbidities that possesses a challenge in diagnosing and treatment, and sir, ever rising antimicrobial resistance. So I felt that I could do something in this branch, sir. Also, there another neglected part is adult immunization, which I myself am not updated, but that is a neglected part. So that needs improvement from even physicians' point of view.
I mean, it wouldn't be really wrong to say that, very passionate people, passionate about medicine per se, would be very much attracted towards a branch like infectious diseases because it encompasses the entire medicine in a way and integrates basic science, your basic history taking, emphasis on examination, paying attention to details, and then, trying to solve a puzzle. I'm sure people have enjoyed watching House MD and all, who was also an infectious diseases physician. But anyway, in addition to this, I just wanted to understand that you were very, persistent. You kept on trying. And what changed every time with your exams, or how did you, modify your approach with every exam, and what really helped at the end?
So first attempt, I was just a fresh pass out of MD. I had no idea how to approach the exam. I thought, let's give this a try. We'll see whatever happens, and we'll take forward from it. Uh, in that attempt, I had attempted 78 questions. I got around 40 correct, 38 incorrect. So then I started. Then I spoke to people who had got through this exam. So what they told ki you should be thorough with your Harrison ID part. So in the next April attempt, I attempted few questions less. 76 I attempted. I got around 48 correct and I got 30 wrong. So again, I could was not able to make through. But however, I felt that that paper was somewhat easier than even this October paper, sir. So I personally even now feel that I should have made it through that paper. Uh, Also, in the this attempt of meeting you at SIDSCon, that was a pivotal point, sir. You made it very clear that majority of the chunk of questions will be Harrison based, and some microbiology images which I need to see from Google or Harrison or Mendel's textbook of infectious disease. So this point also, in the last attempt, I had not gone through the recall or those five videos where you had MCQ discussion. So three to four questions directly came from those topics in both and as well as in October exams, sir. So I think it was more composite. I was more composite in collaborating the things. Also, I integrated things like if I was reading HIV, I'll simultaneously look in at the NACO guidelines, which was lacking in the even the first attempt or second attempt, and this was my third attempt. So, or some suppose I was reading Acinetobacter baumannii. So I'll go through the IDSA GNB guidelines and add whatever is new in the guideline. There may be a question, there may not be a question, but it was important that I should be updated.
That is correct. And also, just tell us, like, how did you think the Marrow modules help? What kind of portions were covered? Which areas you think should be, dealt in with more details? What can be changed? What can be added? Any feedback that you might have?
Yes, sir. Initially, when I subscribed last year, so there were very few modules, around 35 to 40 modules. Subsequently, till April session, there were around 45 to 47 modules, if I am not wrong. And this session had 55 modules, and recently two new videos have been added. So the recent ones, I think it covers a majority of chunk. It like the new NTM topics that is not covered in a great detail in Harrison. Or suppose you have sir dealt with dimorphic fungi. These topics are very high yielding, sir. And also I felt that every exam certain topics are repeated. For example, C difficile was persistent in all three exams. Then talaromycosis or fungal infections, they were seen in both two out of the three exams which I appeared. Cryptococcosis appeared in two of the exams. Histoplasmosis appeared in maybe one or two exams. So fungal diseases, they are asking a lot of questions. Also, tuberculosis. Tuberculosis, the modules which you have taught, they are amazing, sir. And along with that, if one goes through the recent extra pulmonary module that was released by AIMS last year, that covers some almost everything, sir.
Right, right. I mean, those are very helpful points for, people who will be trying to attempt in the future. Also, I've been talking to other people, explaining it to them also that ID is a branch, is a huge branch, like it is entire medicine and entire microbiology, and you try to mix them up. And it becomes really difficult to have very, very concise videos without, having a lot of vagueness about it. Because things will be vague in ID. They're not like 2 plus 2 doesn't make 4 a lot of times, and you have to have a lot of things in the background, lot of information in the background. So I still try to make it as per Harrison's, because although Harrison is not the the end goal when you're trying to manage infectious diseases, but the idea with the module is to make it exam oriented, exam friendly, so that you are able to attempt the questions in the exam. Also, I just want to know, like, do you feel that attempting so many questions was a good idea, or do you feel that, since there's a negative marking, you should probably leave out questions that you're not too confident about?
Again, sir, this I changed after meeting you at SIDSCon. I in first attempt I had attempted a lot of questions. Second attempt, maybe if I would have attempted less, I would have made through that attempt only. And this attempt, I left six questions. I had attempted only 74 questions. As of now, sir, breakup is not available of the theory and interview marks. So I am unable to say how many I got correct and how many I got wrong, sir.
Right, right.
So
And
I
who's
think
the
I
yeah,
think
sure.
for ID, attempting less should be the way to go, as against the other subjects like cardiology or a neurology, where you need to attempt maybe say 79 or 80. But in ID, you should attempt maybe around 70 to 72, 74, maybe.
Right. Because accuracy is what matters. And the questions this time I felt they were really tough. They were not the very regular questions like last time. I personally found that the level was really high this time. And probably that leaving out those extra questions might have helped you in not securing negative marking. And just walk us through the interview, like how was the experience with the interview?
So interview was they initially asked us. There were around 8 to 10 people sitting in a room. They were quite friendly, and they initially asked me that introduce yourself. Where have you done your MBBS? Where have you done your MD? Then they asked, why are you interested in this subject? Why ID? Then from whatever you answer in why ID, they'll pick up those things and they'll extrapolate it and ask you questions. For example, I had answered why, I had exposure of tropical diseases and IV drug abusers, so HIV. Next question was they asked me was what infections are common in which hepatitis virus infection is common in Northeast, as I had done my residency in Northeast along with HIV. Then further, they asked me particularly which opportunistic infections are common in Northeast, where again I had done my residency. So I feel wherever you should know the epidemiology of wherever you are, where basically where you are located from, and where you have done your residency and undergraduate. These things should be known.
Great. Because, ID as a branch is all about local epidemiology. It is all about knowing and reading a lot of stuff. You have to know the local epidemiology. For example, we come across granulomatous inflammation. We always think of TB. But people who are sitting in US or low TB endemic areas, when they come across granulomatous inflammation, they'll probably think of sarcoid or some endemic mycosis rather than tuberculosis. So everything changes with local epidemiology, specifically with respect to the Northeast question, right, where Talaromyces is very frequently reported. But if you're coming to, say, southern part of India or western part of India, then you would not think of Talaromyces that much. So your differentials, your approach, everything changes based on that. Which is why I personally, I mean, I'm working as an ID physician. Obviously, I like my subject, but there's a lot of excitement in infectious diseases. So just talking about the branch a little more in detail. I've come across people, I still come across people who are really confused about the scope of practice of ID. They worry about whether they'll get a good paying job, whether they will be satisfied with their job, whether they'll be able to work as a medicine person or not. So, what was going on with your mind? How did you decide or overcome all these questions?
Yes, sir. So before that, just like to add on to your Talaromyces question. I had this was same was asked to me. Then the examiner particularly asked that why is it more rampant in other states apart from Tripura, whereas it is not as rampant. So that I did not know, and it was important in interview not to fake that these are the people who are making guidelines, and they have been doing that for years and years. If you bluff it, they'll catch you. So, coming to your question, sir, the scope of ID and how did I overcome it, sir? So, after completing my residency, I was I was just confused as other people are. So, I went and did a 10-day observership with Dr. Parikshit Prayak, sir, at Dinanath Mangeshkar Hospital in Pune, sir. So, There I met a couple of the stalwarts in our field, sir. Uh, they guided me, and they told that there is a lot of scope in our branch, sir. It depends how much you want to restrict or how much you want to expand. If someone wants to go into public health, he has an option to go in public health. If someone wants to practice only mycology, he can do mycology. If someone wants to see only transplant ID, he can do transplant ID. If someone wants to see tropical, so he can only see tropical. These things are there. Also, ID offers a great work-life balance. As I have heard from my seniors, I have not yet entered the branch, so I cannot comment on it, sir. You may know it better than me, sir. Uh, what I have heard, so pay may be, sir, more or less equal to medicine guys. Some centers may be low, but for me personally, my work-life balance was important.
Right, right. I mean, trust me that the pay is not an issue. It is as per market standards. Work-life balance is better, and it all depends on how you want to practice and which center you are practicing at. I mean, I work at a center which is very supportive of the branch, and we are three ID physicians in a single center, and all of us are very busy with ID work alone. So when I began my journey, I always felt that I wanted to practice medicine, and whether I'll be able to practice medicine once I finish ID, right? But then I generally don't have time to practice internal medicine. My most of my work is consulting, where people are stuck with, say, difficult situations or they need an opinion, and then I go and consult. But of course, it can change based on the centers, because a lot of centers would want that you should become a primary care physician also, just like any other branch, right? So it is not something unique to ID, but they would maybe want that you become primary care physician, admit patients under you, which is fine. I mean, everybody does it. Only few centers that really understand the scope of ID, they will be okay with, not admitting a lot of patients under ID directly. You can do consulting. You'll have a good work-life balance, but at the same time, you'll have a lot of ownership of the patients. So it's a branch, since it's a new one, it takes a little bit of a time for people to get used to it, for people to trust you with their patients. But as and when you develop relationships, as and see others see that there's an actual difference in the outcomes in the patients, then slowly you will see that the burden of care gets shared with you, and for a lot of things you will become the primary care provider, right? So that is how I have seen in my very short experience. But you have worked with Dr. Parikshit Prayag. I know him. He's a great person, very well trained, very good at teaching also. Other centers, Chennai, CMC Vellore, AIMS Delhi, all centers, they're doing a lot of good work. People are trying to do local research also, right? I mean, ID is one of those branches where local research matters the most. So if somebody is into public health research, they want to pivot from clinical care to something like this in the future after a few years. The scope is great, and like you mentioned, stewardship programs, infection control, transplant ID, tropical ID, every sub. It's just like you're doing a subspecialization called ID, but it's like just doing medicine again, because then you again get a chance to subspecialize in some or the other ID topics. India is not there yet, but in Western countries, they do have very, very, specific ID physicians like orthopedic ID physicians or transplant ID or critical care ID and all that. So, I mean, the future to me looks good. It's a branch that the country needs, a branch that hospital needs, because we are already facing a lot of problems with drug resistant infections. And it is only with the new physicians, new age physicians coming into healthcare, realizing the importance, that things are going to change. I mean, you would have colleagues who would now understand that, this drug resistance is a real problem. Stewardship is something that is necessary. But if you go back to somebody who's like many years experience, who have not been oriented towards all this, they would not realize it. So 10 years down the line, you will see that ID gets more and more involved with clinical care than it is at present. So that's also something that I wanted to share. And I mean, we have covered a lot of things. We have given a lot of points for future candidates to, prepare from, to take help with. And just before we sign off, just want to know, like, so you're planning to join AIMS, you're planning to join PGI Chandigarh. Which place do you think?
So I think AIMS should be the way to go forward, since they have been running the course since 2015 or 16, I think, uh,
16.
almost 10 years now.
Right, right. I mean, hostels, all those things will be great at both places, I'm sure. But always remember that work-life balance predominantly comes only once you have finished a course, right?
Residency, yes.
Most residency programs will be a little tough on you because the environment is also very, very, productive. I mean, it can help you also in a way, it can demotivate you also in a way. I'll explain this because I've been through the same journey. That, AIMS, PGI, they're very academic institutions, and they would love it if you are involved in academics and research. But all of this has to come along with the clinical work that you're doing. So anything that you want to do, you will develop a lot of interest, trust me. If you're passionate about your work, you will find opportunities every day. And you'll be like, let's try to look at this, let's try to look at that. But that will all have to come outside your clinical working hours. So it won't be a cakewalk for sure. It would be just like any other residency. It's a little hectic, but it is fun. You'll have good colleagues, good teaching faculty, good patient load, very good exposure, and the work-life balance will surely be there. But just once you're, about to finish the course.
After, yes.
So that is something that I would like to emphasize, that it's a really, really hectic clinical branch, right? It's not. You'll have certain rotations where you might find a little more time for yourself, but generally it's a busy branch, and it's full clinical work. There's nothing, no doubt about it, that it's not a clinical branch. And that's about it. Anything else? Anything that you want to say at the end, and then we can just sign.
I like to thank you a lot personally, sir, because you have supported me post the April April session. You have supported me a lot, and you have guided me through the journey a lot. I'll always remember that. Thank you very much, sir.
No problem. I'm really glad that we could help you, because we just try to help people. It's eventually your decision. You have to build a career out of it, and in the process, we just try to guide you somehow. And if it helps, it really is a reward for me as well. So that's about it. Thank you so much, and all the best. Congratulations once again.
Thank you very much, sir.